everyone, I just want to say I am beyond thrilled and grateful to this incredible woman, Julie Wiebe, for joining us on this podcast interview, because Julie is not only a master at what she does, she's an orthopedic physiotherapist who has helped many, many people, and she's just been made a professor, but also because she's in the middle of a move. She's just been given a new job. She's got teenage children and she's got a very busy schedule, and she's squeezing us in to talk about something I'm so passionate about, and that is the core. Wonderful. Julie, can you please introduce yourselves and anything else?
Hi, everybody.
That I missed out?
That's a pretty good summary of where I'm at right now. So yeah, my name is Julie Wiebe, and I'm so thrilled to have another conversation with you, Celeste. So learning the ropes as a new professor and clinician, educator, advocate. Love talking about women's health, particularly female athletes, particularly are my jam. But I know that our topic today is breathing. And that is a particular passion of mine because it is such a critical piece of the puzzle for so much of what we do, but we don't really know how to interact with it, particularly as clinicians. But then it's also, how do we communicate it well? You know, there's a lot of layers to it. So anyway, I'm excited to be here. Thank you for having me again.
It's a big, big pleasure. And actually, I was listening to another podcast with you in it, and the interviewer asked this brilliant question, you know, what's the one piece of advice you would give to women out there, especially after they've had a baby? And you were like, they need to sort out their breathing. Like, that's the one thing. And I was like, oh, I need to get Julie on the podcast for the breathing chapter, because, you know, I'm going to organize everything in sections, and this is the breathing section.
Sure.
Well, and I'm so definitely going to get you back for more. So you just have to get ready for those emails to come in. But I wanted to ask you a little bit about that. So let's say we've had a female athlete, maybe she's had a baby, maybe she's got a dysfunctional core. What is it about the breathing, and what kind of issues are you seeing? What kind of insights can you give us there?
Well, I think the first piece of the conversation is that we have a misunderstanding, not misunderstanding. Let me say it this way. We have an evolving understanding of what the core is. And I'm using air quotes. And since we're recording this, I can actually use my hands. So air quotes around core, because it's become a very, very simplified thought process, which is it's just your abs. But really what we understood from the beginning was it was a layered group of systems. And it's a layered group, particularly of muscles, that help us move through space and control our center as we move through space. That's the purpose of the core. It's to create central control throughout dynamic movement, static movements, all that stuff. So what has gotten lost in translation as we sort of tried to simplify, like everybody wants it simplified, which I do too, to like, give me 3 things I can do. You know what I mean? Give me one exercise. And I would love to have that for everyone. But the diaphragm is a part, it's an integral part of that system that helps us create central control. And it's because it's both a pressure modulator, like it actually helps us control the pressure that's part of our central system, but it also is muscularly, a part of that system. And it affects the actions of the other parts of that system, like things like the deep abdominal muscles. Sorry, I'm tired. TA, pelvic floor. Those pieces of the puzzle, they interrelate in their activity to help us create central control. So I may have started off already complicating things, but I'm actually trying to simplify things in order to say the reason breathing is so important is the diaphragm is so integral to how we do that very complicated thing of create central control when we walk across a room or pick up a barbell or run. And so ignoring breathing all this time and just focusing on, say, doing crunches as your core stability activity, we're sort of just missing a huge element. And I think that's so. I think, did I answer the question?
Yeah, you are doing so good.
Okay, so yeah, so to me, it's such a big piece of the puzzle. We need to find ways to integrate it for women in simplified ways, women and men in simplified ways, and that's where things get dirty and muddy. and that's where hopefully conversations like this can help to clarify. So yeah.
Because I think one of the big issues that, I'll just kind of give everyone a backstory. Julie and I were just off camera chatting away about things. And I said, the reason I needed to bring you here, Julie, is because I ran this breathing workshop. And in it, I spoke about, if you grip your core in a static hold the whole time, you're going to end up with paradoxical breathing. And I did an Instagram post about this as well. And man, did I get some, not backlash, but people were not feeling the jam. They were like, no, paradoxical breathing is a really separate thing. I was like, I've heard some really, really knowledgeable people say that if you grip your core, you're going to get paradoxical breathing. First of all, Julie, maybe you can just talk us through what that is, because maybe some people are watching, don't know what that is. And in your clinical experience, what light can you shed on that whole conversation?
Well, I think that, and it's really even, we use the same words to describe different things sometimes, and it just gets muddy. Like, social media is both awesome and muddy, and difficult to navigate. So paradoxical breathing is that this is how we'll use it as our definition here. On inhalation, the diaphragm should descend. So it should come down like a plunger, suck air in, and the tummy and the pelvic floor sort of give in response to that. They open. But what we often see, particularly with folks that have overtrained their abdomen, is that the abdomen doesn't actually move when it doesn't give, it doesn't open when that pressure gradient comes in. Yeah, a lot of people do it.
Yeah.
And so that's sort of that natural rhythm that's supposed to be there as a part of how we set up our central system. So when we impose, so it looks like this. So diaphragm, let me just do this since I've got the ability to do this. So diaphragm comes down, tummy and pelvic floor open as that pressure increases. Then on exhale, diaphragm lifts, tummy and pelvic floor recoil back up. It's sort of this beautiful rhythm between these muscles and pressure. It's this counterbalanced, beautiful thing. But when we impose a habit or training where we say to this part of this beautiful system, you need to stay rigid right here, it's going to have an impact on the way the rest of the system behaves. Yeah. And so one of the fallouts of that I have seen clinically is that instead of breathing and this opening and it to be this beautiful rhythm, women's abdomens suck in while they breathe, and the breathing tends to go up and away from that imposed rigidity. We've kind of created that, but we haven't had a solution. Like, telling people stop gripping your abs doesn't work, because then they're like, but then my back hurts. Then my back, I've been told that my back will fall apart if I do that. I will, but it's also helped them along the way, right? So it's like you're asking me to maybe get rid of something that I felt like really helped me. But what we're suggesting isn't you get rid of the abdomen. The abdomen's no longer important. It's that it needs to be a part of a team instead of just being the only thing we focus on. And
said it so beautifully.
Oh, good.
That is so perfectly summarized in that one sentence.
Oh, good. Yeah. And I think that's where we, and I know we have a mixed audience of clinicians and folks that benefit from clinicians' activities, individuals. And I think that there tends to be this over focus when we over focus on one muscle group, or we over focus on one element of what's going on for people. Like, for example, alignment, like it has to look like this. But what we've done is, and listen, we've all contributed to that, because that's what we've always thought. Like, me too.
I was a part of that for sure.
Well, me too. And the reality is because when we change people's alignments, it helped. So now we need to figure out, it's not that was a bad choice, or that's a bad conversation. It's that we need to understand, why did it help? And then once we start to sort of tease that out, we can understand maybe the elements of that we want to keep, and how we evolve that conversation. But the problem is, we've said alignment is both the source and the solution. The tummy is both the source and the solution. The pelvic floor is both the source and the solution. The reality is, it's the integration of all of those systems and elements that is the solution. Maybe one piece of that system needs a little extra attention, but to understand how the body works, there's no one muscle that does anything. Like, when we talk about the core, the pelvic floor doesn't get you out of a chair. The tummy, the diaphragm, it doesn't do that. It works in conjunction with all of these other systems. And the way that we're taught as clinicians to understand it is very like, it's this or it's this or it's this. And to start to live in the gray and communicate the gray and help lay folk and individuals through the gray, it's hard. Like and I'm not, so I it's very difficult to do that. So we need to start changing up our language, me too, but also sort of changing up our thought process and being willing to say, okay, we can't throw all this out. We got to understand what did work and why it worked and where it created maybe connections that weren't there. Maybe we can guide people using different elements and not, I don't know. Have I gone off onto a rabbit trail?
I love it. You can keep rabbiting on as much as you want. But Julie, actually, I'm glad you paused just because I wanted to kind of clarify a couple of things.
Okay.
Just taking a quick step back, with the paradoxical breathing in your clinical experience, would you say that's something you've noticed?
100%.
Okay, so when you're working with female athletes, particularly, because I think athletes, these people are freaking strong. They can do some pretty amazing things with their body. They're like, I need my core gripped. Like, lady, you don't understand. I'm like a circus performer, a hand balancer or something. I need my core gripped. And now you're telling me that I can't do that because of paradoxical breathing. Like, they were like, no, you need to fact check. And I was like, but I did. I checked with Julie. So I just want to get your clinical experience just for a second, and then we can talk about some of the other things you touched on.
Okay, but so here, let's also be super clear that the majority of the people that I've developed these thought processes around, one, on evidence, like this isn't Julie says, like I don't ever want people to say
it
is. It's my interpretation, and of actual evidence. Like I didn't come up with the fact that the diaphragm and pelvic floor and TA all work together. Like that's in the research, and it's how I've applied that. That is something that I've innovated or whatever. But my patient load is primarily postpartum women. So we're talking about a population of people whose that relationship between the diaphragm, tummy, and pelvic floor has been disorganized by the pregnancy, and that's not a bad thing, it just is. And so what we are continuing to learn is that disorganization means that mamas have to somehow compensate. And when they're offered so they compensated through the whole pregnancy, they've exercised through the whole pregnancy, reinforcing those compensations, and those compensations are appropriate for the pregnancy. But now we're done, baby's here, babe's in arms. And when the only solutions that mamas are offered to recover are abdominal focused, then they start to tip their scales back toward this rigidity in the front and ignoring these other pieces of the puzzle. And so that's sort of the background too that we have to appreciate. And so then flash forward, 5 years, and they've been doing that, gripping their abdomen for 5 years or whatever it is, and they're seeing me. And now that this compensatory diaphragm or pelvic floor fallout is part, it's part of the whole picture. So I don't go in and tell them you're paradoxical breathing. I say things like, look, this is how we understand this system works together. And what's happening, what I'm seeing is that your pelvic floor consideration while you're working out, or your back pain or whatever, balancing all that back out may actually address that a little bit. Like, let's address that. But I do it inside their function or their fitness so that it doesn't, I show them how to use that inside. I give them a new solution versus just say, you just have to stop doing that. So am I making
so basically,
okay.
I think in a nutshell, let's check.
Please.
Let's check if people understand. And I'll be one of your little lay people that's trying to piece it together. When people are actually doing things like allowing the abdominal movement to make space for the pressure changes of the diaphragm sucks air in, the abdominal relaxes, you are putting that strategy inside something that they want to improve on. And that can be as simple as walking or getting out of a chair, and as complex as a handstand. But I think the message is that gripping into a single shape is not effective.
Let's say this: gripping has its place for certain activities, but it doesn't for others. So if you are a gripper Like if that's your strategy for running, that makes absolutely no sense for running. If you are heavily lifting a weight above your head, yeah, you're going to have to create some abdominal
Ooh,
rigidity.
okay, this is what I wanted to ask you about. Like when people hold their breath for like, I think it's called Valsalva, right? They hold their breath,
yes, yeah,
you know?
Yeah, there are times when that's appropriate, but what's happened is when you're provided with that as your only strategy for lifts, then you're going to lift your baby with that same strategy.
Okay.
If you and so let me just back up and throw in a thought here just to make it super clear. So my thought process isn't let's train your this in isolation, which is also what we tend to do in rehab, right? Like let's just do it with these really simple exercises. Is the ultimate goal here, and this is maybe a whole other conversation, is cortical brain reorganization. Okay, so we're trying to make this automatic. And so putting it together in isolation in a couple of rehab exercises, that's not going to do it. Putting it into what means something to your patient, then the brain's going to be like, this is cool. I remember this. Like, let's keep doing this. And they're going to also be compliant. Like, they're like, wait, you want me to go back to the gym? I'm like, yeah. Like, can I try this? Yes. Let's go try it. Because if you try it and we can put in a new strategy and it works, like, oh, wow, I don't have to grip my, you know what I mean? Like, oh, I don't have to do that. And it actually is more comfortable and I'm more powerful. That's huge messages of success for our brain and our body. So we have to appreciate that meaning sends success messages. And then the brain is like, oh, I can let go of this idea and this strategy because I had success. So if you don't ever experience that success, no wonder you're like Celeste crazy, Julie Weeb's crazy. You know what I mean? Like, I get that. So the goal here is to offer you a new strategy in something that so let's say it's a lift overhead with a heavy weight. I would start you with that new strategy at a lower weight. Make sure your form is excellent because that's where alignment, we all finally have gotten back to acknowledging we want you to have good form under a bar. And so, we've got this great form. So now we've actually got better form. You have more muscles. That's what the form is intended to do. Bring in the right muscles, help you support the lift. Let's put that strategy in at a lower threshold, build it, learn it, let the brain absorb it and have success there. And then we'll add weight. And then we'll add weight. That's really what it should look like. And then it's not so crazy to be like, I don't want you gripping your abs while you do this. You don't have to, but they've never been offered any other solution. So that's, so I think that's part of it. So it's a little bit of both.
I mean, at the tip of my tongue right now, I'm hearing what you're saying in terms of gripping is sometimes effective, i.e. breath holding will sometimes be effective,
Sure, absolutely.
But sometimes people shouldn't be breath holding and that's their only strategy that they're using because that's all they know as well. So
right, exactly. So, well, and that's where we need to start. There's this funny conversation that's happening in the world and in social media that you don't like. Female athletes are different and, like empowerment, but in the reality is, well, we actually are. There's like structure there, particularly in the postpartum conversation, that we need to be aware of. We need to be aware of like fascial structures in the pelvic floor and that make women a little more like forces and pressures from above. The fascial structure is different and doesn't resist it as well as the males. The pelvic structure, so we need to appreciate that if we're putting a woman under load, we may need to change the strategy that she's using under that load. It doesn't mean she's more vulnerable. It just means because of how she's shaped and structured, we need to maybe change up our strategy for women. It doesn't mean female athletes aren't empowered or empowering. We just might need to change our strategy. So a heavy Valsalva for 50% of their normal max load makes absolutely no sense. We could do something different. And I promise they can lift 50% of their load without Valsalving. I feel pretty.
Because I see that in the gym, people use very light weights and they're like, and then I'm like, okay, that's good. I always thought that was good until I met you. And then I was like, maybe we shouldn't be doing that. And now you're saying, actually, that's too much preparation for that load.
Right. It's my question back to that person is why? Like, why? And it's not why I'm being saucy. It's like, let's reason through that. Like, I mean, it really, like, as we have a conversation as clinicians, why are we choosing that same strategy for this, for every single movement? It doesn't make sense. And we've also suggested, let's say you have to have good core stability as a runner. Well, if you're a runner, you should not be gripping your abs through the whole run. But here's the thing. The brain will bring up some like general tension in your central control system, but it's going to do just the right amount. It's going to fluctuate. Like, the brain knows what the heck it's doing. It's when we impose these things and train it in as our default that's where we get into trouble. It's this overachievement, probably that overachiever persona that most athletes have.
Oh, such
but
an
we
affliction.
actually have, it is. Oh, I'm there too. So yeah, I know. And that's why, like, I feel I'm never mind. My brain's going in a million places, but we actually have a study that shows us that when they had men jump off a height with their abdomens gripped minimally, because that's the other thing, a light brace is a big conversation out there. And they did it with real-time ultrasound. They taught them how to do a 30% brace. They jump off the height. And what they were doing was trying to understand how it affected lumbar control, because that's what we often dose that for, or lumbar stability, and again, using air quotes. And then it also wanted to see what it did to ground reaction forces. When they jumped with their abdomen lightly braced, they had no change in how well they controlled their lumbar spine, and they had an increase in ground reaction force. Yeah. So
I've read the study. It's crazy.
Yeah. So when we translate that out, that's again, and that's what I've tried to do, is extrapolate that. So if my female runner who's leaking or has prolapse symptoms, if she's running with running form that we know increases ground reaction forces, because this is a conversation we have for knees. Like, we want to reduce ground reaction forces, bring those ground reaction forces below the level of tissue tolerance for the knee. So my thought is, let's do the same thing for the pelvic floor. Let's change up running form, running alignment, so that they get that ground reaction force here. Well, if the mama is also gripping her abs, she's putting extra ground reaction forces on the circumstances. So even if we change their form and put them in these great positions to reduce ground reaction forces, we still may not achieve a dry run if they're still gripping their abs. And that's also force pushing down from above against the bladder and against those fascial structures every heel strike. So it's like that we can't just say, oh, let's just change their running form and they'll be fine. We got to look at how they're using this whole system. And if they are, we got to look above the pelvis, folks. It's a whole body that's running. It's not just legs. So changing up heel strike, or, all that stuff, if they're still gripping their abs above, they're increasing forces from above, and they're also increasing ground reaction forces from below. So we have to change both of those things. So again, you have to understand the demand that the patient or the woman is under, and what the actual application of that system is. And the goal here for me is always automaticity, because the brain does it better than us every time, period.
Yeah.
And so we need to give opportunities for the brain to work it out, and to have that reorganization opportunity at maybe a load they can manage, or a running distance they can manage, and then we build. Like, that's sort of the thought process. And breathing's a part of that.
Yeah.
Because it relieves that pressure, and it works with the abdomen to ebb and flow. I mean, to me, it's just this beautiful marriage. So
totally. I love that word marriage. It's almost like an orchestra playing. And if you just asked one instrument to just bang away wildly and the others to be really quiet, it would sound terrible, And it's like, that's kind of what we've done with this because it's an integrated system. Those words, I think, need to be kind of spoken out wide and far. It's one of the reasons I'm, doing these podcasts, is to just keep reinforcing the message that it's an integrated system, and that we should teach people how to use the entire system and not just one tiny piece of it.
Yeah, exactly. And it also is like, I'm starting to think like, it scales, right? Like, for some people, they're going to maybe need a little more of this and a little less of that. You know what I mean? Like, and that's really the job of a professional. Our job is to look at you as a whole person and sort of begin to sort out, like, how much do we need, how much, it's chemistry, or it's a cookbook. I mean, sorry, don't say that. clinicians should not be cookbooking. I don't mean it that way, but I mean, like, sometimes
We're
you're
awful
like, you need a
cooks.
little more.
Go back to what you're good at.
No, I mean, like, sometimes you're like, oh, maybe a little more salt here would be good, or maybe some more
I
cumin.
know what you
Like,
mean.
some people, like, it's we need to appreciate, and I think all of medicine is moving toward understanding that we need to individualize care.
Yeah.
And you need, as a clinician, to have that ability to sort of balance, like, and what I'm saying too, like, some folks overuse of this system isn't as severe as others, you know what I mean? And so they may not need quite as much cueing, and if you put it into some activity that means something to them, they may they'll move a lot quicker. And anyway, so it's just yeah, and everybody's meaningful activity is different. Some people want to run, some people want to do Pilates, some people want to do handstands. Like, we need to help people find their groove in what they love, and
individualize it, because I think this is one of my bugbears, even though that's my job, is really group fitness is a real problem, because again, we haven't been given medical training, most of us. I have some, but I'm still not an expert. You know, I've done a degree in physiotherapy, but I mean, what do I really know compared to people like you? And I'm on a neuroscience course now, but I mean, even then, when I look at what they're teaching me, I'm like, what is going on? But anyway, it's slowly piecing it together. And I'm teaching group fitness. And now I've got a little bit more knowledge than some people, but even what I know is so little. And now I'm telling people what I know. And I'm really giving blanket statements to entire populations. And on the neuroscience course, one of the things they're drilling into us is the need for individualizing exercise. Is it still a drug that needs to be dosed? And what you're saying is at least the medical world is going that way. And I'm just wondering how long it's going to take the fitness world to kind of empower people in a group setting to actually give themselves the opportunity for something like a test retest, like what actually works for me. And then can they create that culture in a group fitness setting?
That's a very tricky milieu to try to apply this in. And it's also a tricky milieu for you with your platform, for me with my platform, to know how to communicate about this in a way that isn't absorbed as a formula. Okay, so now everybody has to breathe like this. You know what I mean? Like, how do you communicate it in a way that is absorbable and individualizable, and for people to understand that? And also, I mean, you know, it, like you're saying, and I appreciate, my medical training is your medical training, but it's like, and I get the benefit of getting to work with people one-on-one, like and I love that, you know what I mean? But how do you dose it out? And I think one of the things that I've seen a lot of the trainers that I work with as patients, like, it's so interesting to me because I end up having a lot of fitness trainers as patients, That's awesome. Is that they I love it. And I learn a lot from it, but it's an opportunity they usually now start classes with some basic educational rules. Like, and again, you don't want to say rules, because then that's like, it sounds rigid, but it's like they sort of start with some foundational information, and then they're cueing, then that cueing makes sense as they go along, right? And so I think that might be a piece of it. I think
could you share some of that with us? Like, if you had to imagine, all of us listening are fitness professionals, and we've come to you to just say, if you had to give us, I know this is exactly what you're telling us not to do, and now I'm asking you to do it, but because we're so desperate to change the paradigm away from just gripping the core. If you had to give us just a little bit more information to empower people with, obviously the biggest thing is, please go get a pelvic health physio assessment. Please get individualized attention where possible from knowledgeable people. But as someone who's maybe just a graduated yoga teacher, they've just come out of a teacher training telling them you need to grip people's abs the whole time, or they're going to hurt their back, or, you know, like, can you give us some foundations to serve people better?
I think that one of the things that I would communicate is a posture of learning for all of us. Hey, let me tell you what I'm learning. Let me tell you what we're starting to get more research around, is that for a long time, we've understood the abdomen is it's the bomb. Like, we all have to have a really strong abdomen. But by doing that, we've misunderstood that there's other elements that help us set up our central control. And I'm going to talk about it as central control, or like when I say core, if you hear core, I want you to think about the purpose of that. And that's to give you sort of a really strong foundation to move off of. But there's lots of ways we can develop that. And the abdomen isn't the only piece of the puzzle, but we've said it's the only piece for a decade, 20 years, like for a long time, but we're starting to learn something new. And I want to share that with you. Here's what some of the stuff we've understood. And part of it is how we breathe while we move. And maybe the first session, this is what we're going to concentrate on. And this is how it relates to the abdomen. I want to see your abdomens kind of move when you take a breath. I want to see that when you're changing directions in a movement, you're supporting that with your breathing. And, or let's talk about your pelvic floor this week. And this is, if you're working in a group fitness with women, and they are postpartum, you need to be able to understand what might have gone on for them in that department. Communicate that gently. So this whole system is how we're going to get you moving in a way that's positive for your body and makes you feel good. And then the other thing is I would say, I want to make myself available if this is possible. Stay after class. If you're not getting the cueing and you don't understand how this should work, let's practice it inside a movement that you feel really comfortable with. Usually folks know how to do a squat, but if people don't, start with squats. I love putting this into squats. And so,
do one with us, do a squat with us. What should we do?
Okay. So
how would you cue it?
Okay. So, well, this is where it gets tricky because it depends on where they are postpartum, if they've had a vaginal delivery, a cesarean delivery, but let's just go
for non-child delivering people that have gripped their abs. Let's go for simple, really easy. They're just gripping their abs because they've always been told to. That I'm just talking about myself.
Okay.
That's basically my whole life.
So, well, here's the deal. And it's less, I have no idea how old you are, but
I'm 37 and I leak because I've gripped my abs my whole life. And I had paradoxical breathing, all of it, all of this stuff.
So but here's the deal. So you are one of the first your age group, which is the mommies right now. You were the first ones that were told as teenagers.
Yeah.
We need to start gripping. I have a blog on my site about my daughter at 12 being told by her gymnastics coach she needed to have a hard abdomen. Not just her, like this group of girls that were at this gymnastic thing. And he's like, pat your tummy.
And I did ballet. And they were like, come on, suck it in. Because I had I'm short, so a little tummy would pop out. And it's been like that since I was 3, it's not like I was dysfunctional. That's my body. And they were like, suck it in, girl.
I know. And the messages are horrible. And so I taught my kid, well, when they tell you that, you breathe like this. And they're going to think you listened, because what's going to happen is you're going to look taller because you're actually getting this really beautiful full inhale that's going to include letting your abdomen fluctuate. And so I've been able to, keep an eye on that for my own kid. And she's a heavy weight trainer. She loves weights and she breathes while she weight trains. I'm so thrilled. And, so I think that so much of it, we have got to change our messaging for younger generations. We have got to start improving our understanding of this out there, because it creates you should not be leaking, period.
No, I shouldn't. And I'm much better since I've been, learning about things. A friend of mine obviously did your course. She's also a physio, and she gives me all the info. Sarah, hi, Sarah.
Hi, Sarah.
And basically, can you guide us through a squat?
Yeah,
with some cueing?
Let's do it first. This is great. So I'm going to caveat this though, with the reality is that a lot of the people listening have had children. So let's say that you're out of your acute pregnancy. Okay. You're a couple years out. If you're having prolapse symptoms, I might give you a different recommendation out of the gate. So just to make that super clear, but let's just start with that. I'm just putting some caveats on that. And I apologize if you're hearing my dogs. So we're going to do this. We're going to get ready to squat.
Yeah.
And so
we were both wearing our dodgy pants before the call. We were wondering if we should go change. We're just letting you guys know.
Yeah, here we go. And I'm wearing some dodgy pants. But anyway, okay. So when you're squatting, what we're going to think about is coming into that squat. We're going to inhale and let your abdomen relax as you're coming down into that squat. Okay. I probably didn't really actually demonstrate this. So we're going to inhale. So if we understand that idea that the diaphragm comes down, the tummy gives, and the pelvic floor gives on inhale, What that means is as we inhale and relax our tummy, our pelvic floor should be reflexively adapting and also expanding. And then on exhale, so I ask people, especially when they're new to it, to blow before they start moving, to reflexively get that system going before they lift. Inhale down, exhale, and then we're going to lift. So we've let it all out. And it doesn't mean you have to look like you're 6 months pregnant. It's like, just
a big stomach.
Give. You do not.
No, I like my stomach, but it just pokes out.
I was going to say, who cares? Like, that's the thing. You have to all, and me too. Here's the deal. I also hit menopause during the pandemic. And so I have things happening there that I'm
pandemic.
Like, yeah.
Everything is going my way.
And so like, there are things happening here that I'm not happy about, but it's like, I have to also get rid of those messages I'm a lot older than you, Celeste. So anyway, so inhale down. I'm 51. Inhale down, exhale, blow up. Like so this
creates that reflexive activation that we want.
Correct. Yeah. So using breath kicks this system, just ask the system to move, but you got to give. Just creating give here is enough of a good cue. Inhale down, exhale, blow, and then come on back up. And what you're doing is you're not asking that system to work in isolation. You're asking it to be used in the way that it actually functions. It's a part of this movement pattern. And so I'm embedding it. I'm asking the brain to do something. Some women out there who maybe aren't as connected with all of those pieces may need to actually consciously think about letting go of their pelvic floor or lifting their pelvic floor as they learn. But some of you will feel it lift and lower as you do that. And that's a subconscious engagement and a subconscious thing you can work on, or you can do it consciously until it feels more subconscious. But
we can drop the pursed lift breathing after a while. If we get really good at that relaxing, contracting, we can just nasal breathe, right?
You know what? Yeah, that's a whole nother layer. But my job as a clinician is to make it so that it's very automatic. And so if continuing to ask people to do that and you've not rechecked whether or not it has become automatic, like check, is it automatically happening now? Do you have to think about it? Then don't worry. Then you don't have to do that anymore.
Natural.
Yeah. So, right. But then, so let's say that's your squat. Now let's load it. Like if we're going to add dumbbells or we're going to add a bar, you may have to give it some thought again and be really conscious when you change the challenge. Now that becomes automatic. Great. You've trained that neurologically as well as structurally, as well as muscularly. Now we add more load. We might have to give it some thought again because it's a new challenge. We're ready. We got it. We feel it. We're not having symptoms. Fantastic. Let's keep, so it's this idea that you have to keep cueing it. That I don't think that's exactly what you were asking, but no, the goal is automaticity. You don't have to think about it anymore when you pick up a pencil. But yeah, if you're going to pick up a heavier load at the gym, you might have to think about it again.
Yeah.
Right. It's a new novel idea. Yeah, exactly.
It takes time because I've been in contact with your method. And it's not just your method. I don't want to call it your method because this is what the science is teaching. But you have graduated some incredible physios and it's your specialism. And I have been like, right, I have to relax my belly. And I still, after maybe 2 years, I'm really struggling. Sometimes I catch myself I just hold it in all the time. And it's like, man, to break that habit, it's so hard.
Yeah. And, I think that, and here's what we don't understand, like I'm in this with everyone else still trying to understand it, is that there is tension in the system. There has to be to keep us up against gravity, but it's a fluctuating tension because we actually know that on breathing, there's movement in all the joints. Like every time you inhale, we actually have evidence that shows like the joints, there's this subtlety because it's counterbalancing all the time. But we're not aware of it. You know what I mean? Like it's this beautiful system that we get to live inside. I mean,
It's
it's
just
like
automatic,
incredible.
right? The
It's
brain is in
automatic.
charge. Totally.
Yeah. And so it's a little tricky to know, like, where is that line supposed to be of some kind of resting tension? And we get the concept of resting tone because we know when we go to the beach, there's these ladies on the beach that you're like, oh, her biceps are so awesome. And you know, I know. And, but then she's not sitting there flexing. She's not developed.
Like, I don't have that at all, Julie. I'm the soggiest human.
But it's like I know. But here's the thing: we kind of impose that's one, what we're all supposed to look at like, which isn't true, but it's also that misunderstanding that's some kind of conscious tension. It's resting tone. They've created resting tone that she does not need to think about. And so that's the other part of this conversation that people don't understand. Like, if you're consciously holding it all the time, that's not the same thing as having this tension in the system that's appropriate for staying up against gravity. And
yeah,
exactly.
It should be in proportion to the load in question. So if I'm going to lift up a glass of water, that's one load on my bicep. But if I'm going to lift up a 15 kg dumbbell, that's a different load. So my bicep will respond differently. And I guess that's the message around these kind of activations of the middle bodies. Like, is it appropriate for what you're doing? I mean, I grip when I'm just sitting. I'm not sure. I think it's just years of pulling my stomach in.
Yeah, but here's the thing, and this is the layer that we don't totally understand. And again, my goal is to kind of move into research because, let's be frank, we actually don't know normatively what the pelvic floor does inside a lot of these movements. Like, we have a lot of conjecture, but we've not been able to measure it. But we're getting to the point now where we're going to be able to measure it. And but we need to appreciate, and we don't understand how you transitioning from little girl to prepubescent to puberty to full grown woman, you have embedded that strategy into your development. That is deep. That's super deep. So untwisting that isn't easy. But I think what I would say to you is, if so this would be my thought process, and this is without me evaluating you, but since you're your example today, if your primary symptom that you keep trying, that you're like aware of, this is, I'm gripping my abs and this is what the result is, and it's the leaks, and it's inside your exercise program, your personal exercise program, I would say, what happens if you, like, those are exercise programs you have probably done forever. Like, if you're doing them in front of a group, you're probably really good at what you're doing. You doing it at half speed, and I don't mean half speed like slower, I mean like really chilling how hard you have to work to pull it off. I'll bet you are more automatic at those movements than you realize. Yeah. You know what I mean? Like, and I know you probably already know this, so I'm just using you as my example.
No, please, because all I'm learning, listening to you talk, and I think a lot of people are probably getting a lot from it. So please keep going.
Well, but I mean, I would probably say to you, like, what would it look like if you did that same activity and assumed it was already automatic? Like, if because if you've practiced that same move over and over and over
without having to really try so hard at everything.
Yeah. And also, here's the thing: you're so strong and super and overachiever and type, like, all of us, we're such type A's and overachievers. And the idea of not doing something excellently to the like tippy top is like, that can't be right. You know what I mean? Totally. And so I want you to so I think there's also there's so many layers to it as women, as overachievers, there's a lot going on there. And there's no way to, I can't put a research article out there about that.
Yeah. Your job's not to be a psychologist as well, Julie. You're doing good with just but that kind of comes into it, doesn't it?
But I was going to say, I can't separate that. I can't. No, and my experience my experience is mamas. Like, that's who I work with, who are struggling and during the pandemic, it's not, and you're trying to fix you plus keep a human alive. Plus, and
It's a lot for women.
Yeah. Sorry.
So
now the dog is scratching at the door.
I can't even hear him. But I was going to say to you, so you gave us, let's say, blow before you go for someone who's gripping a lot and you want to try and teach them to relax and reflexively engage. How would that differ for someone who has had a delivery?
So inhale down, exhale up isn't the same thing as blow before you go, just to clarify, because that also has gotten so oddly muddied out there. Like, I'm like, what is going on? Like, when I hear my own thoughts out there come back to me in social media, I'm always like, okay, I didn't actually say that. So blow before you go is actually what I would use to ramp up someone's system. Like, if someone came to me as a new mama who maybe has prolapse symptoms or not, their whole system has become affected and disorganized. They just had a vaginal delivery. They need an opportunity to reconnect with that system and re-engage it into movement. So that's a really early strategy for me. And blow before you go is that reflexive, start your exhale before your movements begin. It is not the same thing, let me say it again, as exhale before move, like exhale as you exert. I didn't think of exhale as you exert. That's been around for a million years.
It's before you go to get the system to work at the appropriate time.
It's to help build in that automaticity again. So, and that is for someone who's had the system affected by, say, a pregnancy and delivery. So now what I actually was trying to teach you in that moment was inhale down, exhale up. That's where you're actually using the pelvic floor and the tummy and the diaphragm through their excursions. They go through an excursion. That's how they actually function at their optimal. And so I inhale down, exhale up. And then eventually, if I practice that in, say, a squat, eventually you can't go that slow. They have to speed up, in which case I practice smaller range squats and we do quickies. And then we practice into, and then there comes a point where, I'm practicing this fluctuation, really higher speed. And then I do it on one leg, let's say, because there's going to be a runner. And then eventually I can't train you for the speed that system needs to operate at. My job, if I did it well, was to train your brain to understand using this in a cyclic way and being prepared and having give, so that when you're running, you aren't gripping your abs and gripping your pelvic floor. Like, it has the ability to it's learned how to take load, how to have strength, have capacity in all of these ranges. Like, I've actually taught it to have something happen here, 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 here. You know what I mean? Like, by practicing that, I've helped prepare you for all the eventualities out there, because I can't predict everything that's going to happen. And some runners are rugby players. Some runners are soccer players. Like, I can't predict that they're going to have to they will hold their breath. So I have to prepare them for that. You know what I mean? I have to prepare. So the idea that the pelvic floor just does this is crazy. Like, it has the capacity, and we need to learn more about this, to produce power quick. It has to be able to do quick things. Like, we train other muscles for that. Why wouldn't we train this muscle and this system for that same thing? And so I think that, there's this continuum of cues that we can use and ideas that we can use. Sorry, my computer's that we can use. And so blow before you go is the beginning. That's to ramp somebody up. If someone comes to me like you, who is someone who is potentially over gripping, I might start you with inhale down, exhale up. If you're someone who is really like pelvic pain, lots of gripping, have had, just don't know how to let it go, I do not cue you to exhale. I don't cue you to lift. I just do inhale down, and I use that as a way to open it. And then I let the brain do the rest, and then inhale down and let that.
So you just teach the relaxation, and you just let the brain do the rest, because they've already cued activation so much. You don't want to cue that even more. Got it. Okay. It's starting to click into my brain much more powerfully now.
And so the squat is a fantastic way to do that. So if you are coming to me with pelvic pain, that's one of my favorite things to do, because then it also puts it together with the glutes. Like, for some reason, your brain is choosing to over recruit your pelvic floor for that task. It's not appropriate, or you wouldn't be experiencing pain. Like, and again, there are lots of reasons why people have pelvic pain, but in a lot of circumstances, the pattern that they've developed for whatever reason is over recruitment of that pelvic floor, that's a part of it. Why? My job is to figure out why, not just to tell you relax it, let stress, like it's say, why, what's going on that was your brain's choice. And so I'm going to give your pelvic floor lots of support so it doesn't have to do that alone anymore. That's going to involve the glutes. That's going to involve the tummy. That's going to involve breathing. So it's such a broader thought process than
it's
just
huge.
this. Yeah. And but if we understand the elements and how everything interacts, then we can, as clinicians, say, we're going to give them a little bit of this, a little bit of this, and use really solid clinical reasoning to say, I think you would benefit from learning to relax it and open it in this movement. And I'm going to connect it with your glutes because that's also going to help, take over some of that work like that. So that would be how I might communicate that to a patient. We're going to try this. And then, we put it into meaningful movement. And then the brain's like, cool, I can move and it doesn't hurt. I'm going to keep doing this. And then we build, and then we build, and then we build, so I think, we need to be careful in how we communicate it because there's no necessarily formulaic way of doing it. But that blow before you go is a great place to start. Inhale down, exhale up is another great place to start for some people. It does depend on a few things, and you can try different things. That's the thing, guys. You can try it.
Context
it.
Dependent.
Yes.
And it's not one size fits all.
And then we individualize it.
Yeah.
Then we individualize it. And this is if you are an individual listening, try both of those things and see where you feel either less symptoms, more control, increased mobility. The next day you feel better, see how it affects you. Try one of those strategies and see if there's one that works better for you. And then discuss that with your practitioner or your group fitness person and see if they can help you. And if, then that's you, then you can start individualizing this for you. So
it's very complicated.
Oh shoot. Oh no.
No, you did it in a good way because I think maybe we've oversimplified things. That's why we're telling everyone to grip.
Yeah. Well,
and maybe people need to look at the bigger picture and also bear in mind that everyone is different. And it's not like everyone's different, do what's right for you, because then the body might not know what's right for them. They need to really get some support. And I think the tricky thing is not everyone has access to a pelvic health physio.
I agree. And that's, I know I'm in a lot of circumstances where everyone recommends that. And that would be fabulous, but there just aren't enough. And, the stat I use all the time is that there's about 4 million women that deliver a baby in the US every year. I don't know what this year's going to be like. It's either going to be much higher or much lower. Yeah. I don't know.
Did they kill their partners or did they fall more in love?
We'll find out. Those stats won't lie. But then we have about 3,500 practitioners registered with the section of women's health or the Academy of Pelvic Health here in the US. Wow. It's like nothing. The math does not add up. So I like, now I'm going to self-reflect on a better way to communicate all this, because we have to empower the folks that are standing in front of these women. And if they're ortho,
the yoga
medicine,
teachers and the PTs, that's why I'm doing this podcast, so that the fitness professionals can have tools.
Yeah, exactly. But we also have to be really careful out there. If this isn't we can't make it like so fragile that only certain people can communicate about it. But if you are someone who's out there with a social media presence, for example, or an audience at any level, even if it's your local community and you are the expert, really dig in. Don't just get a few tips off the internet, read a couple blogs, and then repost a few things that you don't necessarily really understand at depth. Like, really learn this. Like, really, but understand that it's all evolving, but you should see improvements. This is for you as clinicians, as lay people. Yeah. Be like, if they're continuing to have low back pain, or they're leaking, or whatever it is during your exercise programs, and you try some of these things and then they don't improve, get more help for them. Get more help for you. Figure it out. And it makes me sad that I overcomplicated, because I'm trying not to, and I'm wondering if you can ask questions to help me simplify it. But
I think I think what you needed to convey was that it is a complex system that is individual. And I think that that's an important message for fitness professionals at large. And I think then the additional layer to that is, if you don't know how to support someone, A, referral, B, go and do some digging, but don't accept that leaking is normal, and don't accept that you have to grip your abs, because you don't. And don't accept that paradoxical breathing is a normal function. Thank God they're still breathing. Yes, but they should be breathing, but maybe we can give them a better strategy. So there should be a lot more, there should be more depth to the conversation, I think. And that's what this is all about.
And maybe that's the takeaway. I struggle. And when I speak and teach and do stuff, I want people to have takeaways. Like, I want there not just to be theoretical. And I think that one of the things that a lot of people struggle with like the biopsychosocial model, which now I'm getting some super gobbledygook for the clinicians out there, but it's like, we get it, but how do you do it? Like, how do we actually like work that out in steps? And I think, so if I could simplify, I'm trying to think what could just try different strategies and see which one fits best for you or for your patient. Like, try some things, but don't do it in isolation. Do it inside of meaningful movement for them. And if you don't know what that meaningful movement is, find out. Ask them. I ask my patients, give me 3 things that you miss, that you cannot do at the gym, that you cannot do at Pilates or yoga or whatever. Let's try to implement this into those things, so that then you can practice within those things. Let's see. And that becomes your test retest. Can you do it better? Is it less painful? Is it less, so it's find out about strategies, try different things within reason, and watch for how they respond to it.
What everyone should be doing is Julie's online courses, because you've got a plethora of research that you present out into the world. And, maybe you can tell everyone a little bit about how that can support, if you're a fitness professional, and how that can help them support their clients.
Yeah, I was actually thinking, there is a very short module on my site that's actually appropriate for, I've tried to make the language really appropriate even for individuals as well as clinicians. And it's called Breath Mechanics in Your Pelvic Floor. It's like a 30-minute thing. And it takes you through that continuum, like where you might use the breath strategy. So if nothing else, that might be enough, just to give you some basic ideas. If you are an individual, I have a program on there that's called the Pelvic Floor Piston or Foundation for Fitness, and it's for lay people. Like, how do you start to pull these pieces together? It is intended to just be the beginnings. Like, how do you start to pull this together? And then the idea is, once you've sort of connected with those pieces, because some people do need a little more time, then put it into something exercisey. It was originally done for a research study. So I had to be very specific on how I did it. But anyway, and then for the professionals out there, I have lots of information for you guys. There's courses that run through this in terms of very specific basics. And this is the rub in education too. You have to understand the foundational pieces and know how to put them together. And so that's really my first course. It's called Diaphragm Pelvic Floor Piston for Adult Populations. One of my long time ago colleagues started calling it piston science, and I loved it because it's just not a mouthful. But that's part 1, those foundational pieces. But then recently I put out the Treating and Training the Female Runner or any female athlete. And that's really the clinical reasoning. That's where we get to really play with all these elements. I love that class, but you do need some of those foundational pieces. So if you could do those in combination and do some of them, some of the beginnings of this, and then see the application, like, don't miss the application piece. Like, don't stop, please. So because stop really it's
believing.
But here's the thing. I think that clinical reasoning is what we need. That's, it's not
taught in the fitness world at all.
Yeah.
It's one size fits all for everything.
Yeah. For everything. And it's that way in rehab too. Low back pain, here's your packet of exercises. You know what I mean? And I think it's really, so I cannot, and I think this is where, we have to be, when I do these things, it's so hard because I'm trying not to make blanket statements, but then it might muddy the water. But if you have clinical reasoning, and I actually just taught this to my students last week, it's a portable skill. You can take that skill into every single interaction that you're in. If you take a formula in, it will run out. But that clinical reasoning capacity, and if you really want to develop and hone that treating and training the female runner is a great way to do that. But get some of those foundational pieces so you know what you're reasoning around. You know what I mean?
Yeah, and Julie, you know, I'm probably going to show now just how sometimes slow I can be, but I remember sitting in university. I don't know how I got in. And I just remember them talking about clinical reasoning. And I was like, I have no idea what they're talking about. And obviously now, many years later, I'm like, okay, obviously you look at the individual, you look at how they present, and you try and use all your knowledge and all of the research that you've looked at, and then looking at the individual in front of you to come up with a set of conclusions based around that particular case. But is there anything else you want to kind of empower people around the clinical reasoning conversation?
Yeah, so that's one in my head. That's the beginning. Like you're taking in all this objective information, right, with your background, informing that. And then that is intended to take a first step, right? Like then you take your first step. And that's where the real clinical reasoning begins. Why did that work? Why didn't it work? Let's start to put together.
What can we change?
What can we change? Why did she respond and she didn't respond? Yeah. What can I learn from what didn't work? And what can I learn from what did work? Why was she different? You're 100%.
You are a detective.
And that's it. Yeah. And
you would never walk into a crime scene and go, well, the last murder I saw was XYZ, so that's exactly this murder. You would not do that as an investigator.
No, you look at blood splatter and you look
fingerprints,
at the relationships. Like all
who
that
was
stuff.
here?
Like,
what
was
time?
It a break-in? Was it a forced break-in? It's funny that you say that because I told the students last week, I'm like, it's like you get all these piles of information and then you tack them up on the wall with the yarn
with the lines.
Like it's a crime. It is. You're solving a crime. So I love that. But that's it. So it's not just we come up with, okay, we got it. This is a mechanical back problem because we know all this stuff. That's only the beginning of clinical reasoning. Yes, you had a vaginal delivery. Okay, that means you need pelvic floor PT. Great. But it's really like, what now? What? Like you got to step into that and start trying things. And then you say, okay, why is maybe someone who's had a cesarean, this might be a more appropriate way to start for them. Okay, but not every cesarean is going to fit that. But then you start to build in some of that ability to, with your experience, have a little more intuition on where to start, how they're responding quickly. You know, that's really the clinical reasoning. How do you start to be self-reflective? How do you build that? It's a skill that you can build. How do you start to be self-reflective? Yeah, but I think it's an entering in. Like once you start asking why, okay, it's not just that, yes, the pelvic floor is tight. Why? Like I get it's not just now we need to do these 6 pelvic floor things. It's why. What else is going on? And it could be psychology. It could be that we have trauma. It could be that that's what they were taught to do because they're overgripping their abs and the pelvic floor is responding to that. That's the solution, not just getting her to relax her pelvic floor. She has to learn how to relax her tummy too. You have to get to the why. Otherwise, you're treating a diagnosis. You're not treating the person.
Beautifully summarized for us. And I'll end on that note because I know you're very busy. And I am so grateful to you for your incredible energy. Your passion glows through every single word. And I sincerely in my heart hope, I don't want to say the word hope, I have faith that as you and as you have taught me and you've inspired me, and I'm so passionate about it, and I fly the flag, and I just want to get this kind of information out into the world even more. And I'm hoping that people that listen, I have faith that people that are listening are going to go forward and share this message that, you know, our bodies are very, they kind of already knew what they were doing before we started throwing around all these cues, you know. We kind of messed up things a lot along the way. But having said that, on the flip side of it, you know, for example, a mama that has delivered, they do need some rehab and they do need some support on getting back to where they were. And so there's this delicate balance. And learn, guys, learn more, especially from people like Julie, because it really is a gift, the knowledge that you have.
Oh, thanks. Well, I so enjoy talking to you always, and I am so grateful. Those are very kind words, and I think we need to start to see our roles differently too. We need to see that we're guiding people versus imposing something, right? And so that's what you maybe just think of. But anyway, thank you, thank you, thank you. It's so good to be with you. Good luck with your move.
Thank you very much. And
Yeah.
Julie, can you tell everybody just how to get hold of you, where they can find out more about you and the things that you offer?
Yeah. So my website is Julie Wiebe, and you can actually misspell my last name and you'll still find me. JulieWiebePT.com. My last name is actually spelled Wiebe. And there's all sorts of resources there that you can look. You can just use the search bar and type in something you want to understand. There's blogs, there's videos, there are the courses. I do have a newsletter. I promise I don't bug yet, but heads up, my newsletter subscribers get discounts. Anyway, so newsletter is a great way to keep up with me, and I'm in the socials. But this new role as a professor is there's some adjustment time here. I need, but I'm enjoying it. It's fantastic. I have great colleagues, but so I'm not quite as present, but right in this moment out there, but trying to be. So
that's okay, Julie. You just do you. I think you've given enough free information out there to serve a population for a lifetime. Guys, do check out Julie, and a big thank you yet again for Julie.